interventions. I'll be mostly focusing on the mitral clip, but I will briefly go through some of the recent developments in the imaging modalities for structural heart interventions. Before that, I thought it will be very nice if we can briefly go through the history of echo and why echo is so important. It has come through a lot of stages. So it was in 1950s when the two physicists in Sweden, in one of the universities in Sweden, they came up with the M mode, and that was the birth of the ultrasound scan. So if you think about it, it's not that old, 70 or 80 years, it's not a long time. In the 60s and 70s, it was the work of Harvey Feinbaum, who added the Doppler, and the 2D echo developed much more in that period of time. And in those decades, the transthoracic echo and the Doppler sorry. Okay, sorry about that. So it was the decade of 1970s when the echo, the transthoracic echo, and the Doppler was used much more in the assessment of the valve disease, the chamber sizes, and the function. And I thought it will be appropriate to put some pictures of these legends of the echo. So we can see Harvey Feinbaum on the left. In the middle, it's Hertz, and then Eng Edler, who was a cardiologist in Sweden, who went ahead with the echo. In the 70s and 80s, the transesophageal echo was developed. It overcame many of the difficulties that we have with the transthoracic echo windows. Then in the 90s, the 3D echo reconstruction basically transformed the structural heart interventions. In the last 2 or 2.5 decades, we have seen the transformation of the structural heart intervention because of the 3D echo incorporated in these procedures. So in the structural heart intervention, why the echo is so important from the TAVI, which has moved on to more of the CT guided now to the mitral clip. It's important for the patient selection, for the procedural guidance. The operator cannot do anything without your TEE. Then the assessment of the immediate results and any complications which should be dealt with straight away. Where do I point this? All right, okay. So the multimodality imaging, they are going to be the cornerstone for a structural heart intervention, from the pre-procedural imaging to the procedure planning, and then the guidance as well. I wouldn't give much time to these slides, but when it comes to a procedure, especially the mitral clip, the left atrial appendage device, it's echo guided and only fluoroscopy assisted. So the echo is going to be the key in these procedures. The tower, as I said, it's the CT, and we have a talk on the CT assessment for the tower. The mitral clip and left atrial appendage, it's the domain of the echocardiography, and CT has a very limited to play there. So the main purpose of my talk is the mitral valve H2H repair. The mitral clip is the most common of that, and I will be referring to that as the device for this procedure. And as I said, it's going to be TE guided and fluoroscopy assisted. When we are selecting a patient for the mitral clip, the selection is based upon the Everest 2 criteria coming from the Everest trial. There should be moderate to severe MR. The pathology, ideally, they said it has to be an A2P2, although we have moved on from that, and any area or any part of the mitral valve can be targeted for a mitral clip. The co-optional length has to be more than 2 millimeter, and the depth less than 11 millimeter to avoid the risk of the clip failure. The flail gap less than 10 millimeter, and the width of less than 15 millimeter. The orifice area of more than 4 centimeters square is needed for these clips. So once we have selected a patient that this patient is favorable, has favorable anatomy for a mitral clip therapy, we go on to do the 2D and the 3D TEE for these patients to further assess them. It allows a detailed assessment of the mitral valve apparatus. And the very important step is going to be the interatrial septal puncture. And for that, we need to assess the patient beforehand, before taking this patient to the cath lab. I will briefly go through the key views. So the main key view is the bicommissural X-plane, which is X-plane to the LVOT. So the 3D, the machine needs to have the 3D software to guide these procedures. And then we sweep from the lateral to medial or medial to lateral, whatever we are comfortable with, to interrogate the leaflet anatomy, pathology, the leaflet length, the jet location, and then the grasping location. That's where the LVOT, the 120-degree views, comes into play. The 3D en-face view is very important, and it's very important to get it right so that the imager and the implanter are on the same page. You need to do your Z rotation so that your aorta comes interiorly or on the top of your mitral valve, and the commissure needs to be at 10 and 2 o'clock, and we put the color, and I'll be showing some pictures of that. Then we need to have a very good bicable view, and we explain it to a reverse aortic valve short axis view. This is very important for the optimum septal puncture spot, and then also the 4-chamber view for the height of the puncture. So once the patient comes to the cath lab, we reassess the mitral valve. We make sure that the mitral valve is still suitable for going ahead with a mitral clip. We want to make sure that there is no left atrial or left atrial appendage thrombus there, because there's going to be a contraindication, and we look for a presence or absence of pericardial effusion. So those are going to be the key views for the assessment. So as I said, we do a bicommissural view, which is X-plane to an LVOT view. And in the next slide, we put some color there. We just want to make sure that we have the mitral regurgitation, what we are going to treat. So this is going to be the sweep. So we start from the medial. We assess the medial part, we go to the central part, and from that we go to the lateral part as well. And again, as I showed in the Everest criteria, we want to make sure that we have the appropriate anatomy to make our clip successful, so that our leaflet length and the location is appropriate for the procedure. How do I go back? Next, please. So there's the 3D en-face image. So as I said, when you take the 3D, the aorta is not going to be there. So you have to Z-rotate your image to bring the aorta on top. You want to reduce your gain to reduce the artifacts there. You want to put some color there to make sure that your mitral regurgitation and the area where it's coming from is appropriate for the clip. So as I said, the interatrial septal puncture is very important, and you need to assess it, and you need to plan it very properly. So it has to be posterior and superior, and there are 2 views for that to make sure that we are going in the right place. It's very important to guide the operator that he is not through the foramen ovale, because the foramen ovale is usually a posterior, it's an interior structure, and you want to go posteriorly. You also want to avoid an ASD. You don't want to be going through the ASD, because then you won't have any support for your delivery catheter. So those are the key views for interatrial septal puncture. You have your bicable view with your SVC and your IVC, and once your puncture needle is there, you want to explain it to an aortic valve short axis view. So the aortic valve is interior, you want to be posterior from there to avoid any injury to that. The 4-chamber view for the height of your puncture site, ideally it needs to be more than 4 centimeters so that you have the proper space for guiding your mitral clip. So just a demonstration of the same. So usually the imager guides the implanter that you have got your needle in the SVC. He brings the needle down, sliding it along the interatrial septum. Once you see a tenting, you put your pointer on that and you go to a reverse 4-chamber view to make sure that you are puncturing it in the right position. And then you go to aortic valve short view, which is explained to a 4-chamber view to make sure that you are away from your aortic valve to do the proper puncture there. So once you are in the left atrium, then the left atrial appendage and the left upper pulmonary vein are going to be your targets there. So 60 to 90 degrees is the best view for that. We have to avoid the left atrial appendage. The operator will take a long time to make sure that they are not in the left atrial appendage, because a stiff wire will puncture the left atrial appendage and all the complications will occur. It might need to be pre-dilated, but usually the operator will guide you on that. Once we have got a wire there, then the steerable guide catheter is advanced into the LA, and from there it is positioned towards the left ventricle across the mitral valve. Usually the operator does a few runs up and down to make sure that the orientation is correct. Then comes a few very important views. So you still hear your bicommissural view, which is explained to the LVUT view. And in the LVUT view, those are called the grasping view. So in the bicommissural view, you wouldn't see the wings of the mitral clip. The wings of the mitral clip can only be seen in the LVUT view, and you want to have the nice opening of the mitral clip wings there. Then you go 3D anphos. Again, as I earlier said, the aorta needs to be in the anterior to the mitral valve, and the clip position is confirmed there. So once we are happy with the clip position, we want to make sure that there is a good grasp. So the TE comes into play again. There is minimal leaflet motion. Overall, the leaflets are very tight, and there is a formation of a very stable bridge, anterior-posterior leaflet bridge, to make sure that you have implanted the clip properly. And that's where it is shown. You have got your clip there, the mitral regurgitation, which was there anteriorly, and then also the imager guides the implanter that they are happy, and the implanter would go ahead and release the clip. So the clip cannot be released without the imager telling the implanter that now they are happy with the position. So under TE guidance, they will release the clip, the delivery system will be removed, and that will be a point of no return there. Any possible complications? We'll put some color on the intra-atrial septum. If there is a large ASD, you might want to close it. Majority of the time, it's not needed to be closed.
2 minutes remaining.
So I will just briefly say how the 3D echo has changed the practice. I think as in CMR, we say there's a virtual histology. The 3D echo is a virtual surgery. So with the 3D echo, the implanter exactly can see what they are doing. And without the 3D echo, it would not have been possible to have those advancements in the mitral clip or any structural heart interventions. I would like to say that the near future is going to be interventional echocardiography. They are an essential part of the structural heart intervention team now. There are guidelines on that. There are training programs. And I think any of the budding echo or the imaging cardiologists should follow these paths. The future also lies in the fusion imaging with the fluoroscopy, with the CT data set. This is going to be the future. The imagers are going to be in the cath lab, fully taking part in all of these structural procedures. So my take-home message would be that it is the cornerstone of the structural heart interventions. Different modalities are needed for different procedures, and it is essential for operators to be able to perform and interpret the images themselves.